Okay, our last speaker for the day before our roundtable is Jane Smith. She's the Technical Manager of Scientific Affairs at Lear. Jane Smith received her BA in Medical Technology from the University of Tennessee at Knoxville and received her master's degree in Science Education and Environmental Engineering. She worked as an immunology supervisor for 30 years at the University of Tennessee in Knoxville before joining the Lear Clinical Immunology Group. In 2011, she was one of the founding members of Lear Scientific Affairs, where she now serves as a technical manager. Jane has been active in volunteering nationwide for CAP inspections. She also has volunteered on CLSI Point of Care 04A3 Point of Care IVD testing and the QM ISO3 training and competence assessment documents. Jane is currently directing a cross-functional IQCP team to provide IQCP support materials for Lear products. And let's welcome Jane Smith. She's going to be speaking on individual quality control plans.
Thank you, everyone. I'm going to see if I can learn to work all these electronics. First of all, I want to make this a very interactive presentation. So I'd like a volunteer to be the mic holder for questions as we go along. I think these both work, right? And second of all, I talked to some of you out there, but I'm going to put on this table up here. These are USB drives for all you guys. These are current IQCP support documents from Lear. And there's guided instructions on how to use our Excel spreadsheets, which I'll talk about as I go through the presentation. The back of the SUV drive has our webpage. It has a link to the CMS site that if you want to use this guide, I am going to talk about this guide in this presentation for putting together your IQCPs. I hope this works. Yay! We've already talked about me. In general, I'm a medical technologist. I tried different things in my career. I was very fortunate in that I worked for a university hospital, and all my upper education was absolutely free. And I did it part-time as I worked through all those years. All right, folks, the time has come. And we're going to do an exercise here. I would like anyone who has completed all their IQCPs to please stand up. And we are going to applaud that person, 2 people. All right. Now, next category. How many of you are just gathering information? You have not even started writing one yet. The truth's come alive here, folks. Anybody stand up, brave enough to stand up? How about 25% written? Ooh, we got some scared people in here. 50% written. There's one. Yay! Progress. 75% written. Yay! Look at the statistics up there, folks. We're talking 68% of these people. This was a recent survey. This was the survey of, I don't know if you caught a Lear's microbiology IQCP webinar we did this past week. This was the data from 1,000 participants, and that many people are not even putting pen to paper yet. They're still gathering their information. I also did this at a point of care meeting in Tennessee. I had a CLIA inspector from Tennessee present, and we're talking 70% of the room did stand up and say they are still just gathering information. And that inspector turned around, and I'm not telling you, she shook her finger at all of them and says, "You better get going." So, how many do you have to write? Let's see who the real champions are. Who in this room has to write greater than 11 IQCPs before January 1st? Oh, I see a hand back there. Okay, what about the category of 5 to 10? There you go, more hands. 3 to 5? There are a few. And 1 to 2? Okay. What's keeping you from working on this? No time. It's got to be no time, right, folks? I know that. This takes a lot of effort. I really understand that. Not sure how to get started. I think in the last 3 months we're getting there, but this was just last week, I'm serious, when I did the survey. No interest. I actually put that as a response. I felt almost guilty to say no interest, but I got people saying they just really weren't interested in doing this. Well, what I hope today is to go over these things. First of all, I want to talk about where we are right now as far as the regulatory agencies, what to inspect from the inspectors from what we've kind of learned, pen to paper suggestions on how to do your risk assessment, quality control plan, quality assurance plan. We're going to do an actual live practice IQCP. And finally, we're going to give, from working on this, our helpful hints. And we get about 10 of those. We know January 1st that we have to have this completed. You can do the default 2 to 3 levels of QC, per day, or you can do IQCP. Be careful. This doesn't mean 2 days after January 1st. They mean you have to have this ready on January 1st. It's not going to be grandfathered. They're going to expect, what I really believe inspectors are going to do is they're going to go look at your data on your non-wave test on January 2nd and make sure you have this all put together. Even if they come in March, they're going to go backwards and look at it. COLA, CAP, Joint Commission, they all agree on this in CLIA that this is going to happen. I don't think in Minnesota we have to worry about any local or state regulations. You guys are pretty straightforward. You've got the choice of doing IQCP. The inspectors, I think, are going to be lenient the first round. They are just going to be excited if you've worked on a plan, and they're going to be looking at the process to make sure you've included all the steps. And first of all, they're going to say how did you develop this IQCP? Did you sit in your lab office and did you consult with any people when you worked on this IQCP? Main thing is the operators and the end users. Those people all need to be included in the process. Was the data used in the risk assessment of reasonable quantity and quality? First place I've seen any mention of how much data to look at was 2 years, and it's in that guide that CMS and CDC put out. Now that seems like a lot of data to be looking at, but really you're not. Remember, you're doing your QC reviews, which most of the time QC is acceptable for all different things, but you're looking for the ones where you had exceptions and corrective actions. So keep that in mind. Is there a process to monitor and review your quality performance, your QC, and what you've got to do is link all this back to your risk assessment. An IQCP is not, SOP is not required by CMS. But I can tell you it's good laboratory practice to do this, and I'm sure you guys are going to be doing that. But when you do your quality assessment and you work on your quality control plan, you are going to have to make edits to your SOP because you've got to bring in all these points from your risk assessment. So to say you don't have to write an SOP is really not a correct statement. My Tennessee surveyor from CLIA said she even wanted a SOP about the risk assessment and how you looked at your data and things like that. She emphasized that identical devices, you can have one IQCP, but you need to be very careful. You want to, like neonates is going to be different than in a cardiovascular unit on specimen collection, patient types, all those different features. I suggest in an Excel spreadsheet that you, for those exceptions, you make a tab for NICU or cardiovascular units to keep everything straight. Again, this organization is totally up to you. They're not going to be critical of it. They're going to be very excited, even if you have something to present, I'll be honest with you. You're going to have to do your review of your quality control plan, the routine failure investigations, corrective actions, preventative actions. You guys are already doing that. But again, you've got to link it back to your risk assessment. If you have a problem with your quality control, you have to redo your risk assessment and take a closer look. The annual review of your quality control plan, people are asking, how often should your IQCP be reviewed? It depends on the circumstances. If you have a quality control problem, you're going to have to review your quality control plan more often than once a year. So it is all linked to if you have to do a corrective action and do your risk assessment again for any reason. Again, this book is wonderful. If you haven't gotten it, I really think it's worth the read. This is what we're hearing from the Joint Commission. They want you to make sure that this is basic in lab. They're very straightforward. They expect you to do accurate and reliable test results that are appropriate for your patient care. It's no matter what quality control you're doing, you've got to provide accurate and reliable results. You need to ensure that the IQCP meets the requirements set forth by CMS. The quality control plan, you can delegate in writing to qualified people in the development, but they need to be certain people. They have to be a technical supervisor or a technical consultant. The laboratory director does have to approve and sign. After the first year, even the laboratory director can decide to delegate the reviews after that. CAP, they have some specific checklist questions. The .50200 is they want you to list what you're doing IQCPs on for the inspectors. And they also want you to fill out a form for individual quality control plan summary. They are more strict than CMS. They require a non-weight test to have an electronic control, procedural control, built-in control to qualify for them for IQCP. Exception is microbiology media and microbiology testing. If you did not catch our webinar with Dr. Susan Sharp, it was an excellent summary for microbiology. I know you guys are mostly point of care in this room, but if you know anybody that needs, some really good, she called it real-life examples in microbiology, and she gave examples of systems with IQCP's examples plans. You can go to White Hat Communications /Alir or just email White Hat, and you guys are familiar with White Hat, and they will get you to that recording and the slide set if you're working on microbiology. If you're an Alir customer, and let's say you want to do IQCP on our strep pneumo, guess what you're going to have to buy? It's because CAP is going to require that you run those controls every 31 days. No one else has a time limit on how often you have to run your external controls. So again, you're going to have to make arrangements for these changes in IQCP. This is 2 more requirements for the quality control plan. Again, provide for immediate detection of error for all the phases. You have to specify the number, type, and frequency of testing for QC materials and determine the acceptable criteria for QC. You guys are used to doing this. This is probably in your procedures already, but they're really drilling it down. Same requirement as Joint Commission about signing the IQCP document. Following manufacturer's instructions, make sure you do that. And the other thing that people are going to forget, getting all into IQCP, is there are additional checklist questions that CAP is going to require that you do that are above and beyond what you think you can write for an IQCP, so do not forget the checklist questions. The best example I can give to you is the lot-to-lot comparisons. Just because you're doing IQCP, that does not eliminate doing those kind of things that you have to do for CAP. And here's the example form from CAP that you need to fill out. I was talking with the customer, and she says, well, I finished my IQCP. She says, now I've got to take the time to figure out how to fill out all this documentation out for CAP. So it's going to take a lot of time, folks. Just be honest with you. Just be prepared to do if you're a CAP inspected lab. Joint Commission doesn't require this. Your state people don't require it. But CAP, if you're a CAP lab, get ready. You've got extra work to do. Quality assessment, this is stuff you're already doing, but you've got to link it back to your risk assessment. You're going to, the 5 categories that are required by IQCP are, reagent, specimen, environment, test system, testing personnel. Somebody, I think Abbott described this as STORE. If you just change testing personnel to operating personnel, an easy way to remember it is the word acronym STORE. You're reviewing the things you have to review all the time. Your quality control, your proficiency testing, patient results, rejection logs, turnaround time reports, anything in quality assurance that you're doing in your monthly reviews. This is what you need to connect if you've got a failure in those areas after review to your risk assessment. There are some programs that are out there to assist you with doing this in an organized way. One is that's by COLA. It's about a 77-question survey. A lot of people like it. Also, somebody here, who said they were using the CRI one from CarePoint? And we got some hands, okay. It's very detailed in that they've done some of the preliminary work of doing the detail for the exact test you're working on, your IQCP test. And with that program, you buy just the system or assay? Did you buy like a system or like for each analyte? I'm sorry, I can't hear you.
It's just the program.
She just got the program.
Oh, I haven't used it enough. Okay.
No, we used it. We just bought the questions.
Okay.
The program that you use it. We didn't get it for the individual tests.
Okay, you didn't get it for individual tests. Okay. They were originally going to sell it per individual test, so they must have changed that. Okay. Again, you don't have to use this software that's provided by these companies. It's up to you. Excel spreadsheets work great, and I'm going to show you how to do it with Excel spreadsheets so you don't have to spend the money if you don't want to. All these are very helpful emails. I've used them. They work. The CMS email there, her name is Penny Keller. You'll hear back from her. The girl must work 24/7. I'm serious. It's really funny. Lear, we want to talk about our sites for you. On the back of the drive, that'll link you to our webpage for IQCP help. And also we have an email. That's for your questions that, no, we could not answer all your questions on our webpage. That email is for, very specific questions about your IQCP. And I'm usually one manning the emails, so I'll do my best to, answer it correctly for you. These are things you can do right away if you haven't gotten this far on this. You've got to make a team. That laboratory director has to approve and sign. It's his responsibility of running that laboratory that he's approved each IQCP for each system that you're going to write one of these for. He can delegate to that technical supervisor or technical consultant. I encourage you to get other people involved in the process. And examples of people are phlebotomists, the people who collect the samples, respiratory therapists, lab processors, quality assurance people, physicians, point-of-care coordinators, you guys. A lot of you, I'm sure, are participating and helping, right? Medical technologists and nursing. Again, get a team involved in doing this. The 3 parts, you guys already know that. You're this far along, but just to go over the basics. Three parts: risk assessment, quality control, quality assessment. Let's go over the risk assessment. Getting ready, vendor information, laboratories, policies, and procedures. Clinical requirements, that's where that team comes in. How vital is that test result in that area? Could maybe point of care be eliminated, or why point of care is vital, that way it can't be eliminated? Regulatory requirements and your package insert. And what you're going to do simply for risk assessment is map out the process. What could go wrong? That's the failure. How likely it is to happen. How bad it could get. And what controls you have in place to prevent failure. Here's an example of just doing a flow chart. I'm not a big fan of this. Some people are very visual. That's what they like. Here's a fishbone, another one. I would take my CLSI procedure that's step by step and just make a sheet of paper and then write out to the side where all the failures could happen instead of going all this work of making these nice diagrams. But I'm into doing it fast and dirty and figuring this out and putting it in an Excel spreadsheet. It's all up to you. Don't forget, you've got to look at pre-analytical. They call it analytic, by the way, post-analytic, and analytic in the guide, so I'm going to change my verbiage someday. And remember those 5 areas. I've heard them call it the 5-3-3. If you can remember, those are the parts that you really got to have for that inspector when they come on site. Again, you're going to have to collect your historic data. If you guys have been doing EQC, make sure you use it. It's a great way to segue into going into IQCP. Identify your failures, where the failures have occurred, calculate the frequency, and evaluate the potential impact. One thing that Dr. Sharp talked about is you'll see these summaries that she's written, and in her summary of all her data, she specified the time that she looked at her data. So if you went back and looked 2 years, state that's what you did. Talk about your internal, external QC reviews. Talk about your maintenance, performance checks, any corrected reports or physician complaints that are coming in from quality assurance. Do you really want your inspector to dig through 2 years worth of your information when you could maybe in your IQCP report give them a nice summary and tell them where all the, what the summary is of the information? Your inspectors are going to appreciate that because they don't want to dig through all your paper. Now, you do have to have that paper there as part of your documentation, but again, make it easy for somebody to inspect you. I'm doing the risk analysis. Some people maybe are more comfortable with the risk analysis part, but the best examples that I would like to give is two of the extremes. A negligible, improbable event, is this an acceptable risk or not? And if we go to the next slide, it's not. For instance, a hospital decided to use a new device for collecting heel sticks in a NICU. They got an increase of complaints on bruised heels on those babies' heels. Well, okay, was it the new device that's causing the problem, or did they do inadequate training? Again, this is how you're going to have to look at things when you bring a new process into the lab. Now let's go the other direction. If you had a catastrophic event, but it was very improbable, there you go, it's acceptable. Maybe you guys are more comfortable with that now, but a lot of people aren't. Best example that in a laboratory I can think of is emergency release blood. They do it all the time, folks. That blood is not adequately screened, but that person is going to bleed out if they do not give that emergency release blood. So these are the things you need to consider when you're trying to figure out if it's an acceptable risk or not. Quality control plan. We used to not really go into detail of this. We kind of thought you guys are comfortable with doing this in the lab. But what we found was the regulatory agency, we're drilling down on certain details. So now we've decided to go in a little more detail for everybody. You can't do anything less than what we recommend as a manufacturer, local, state, or accreditation organizations' requirements. Again, the lab director has to do approval and sign in dates. You're going to have to take a look after you do your risk analysis of what processes need more controls. You need to link your existing QC procedures to the failures that they prevent or detect. And take a second look at all the QC processes you're doing in your lab. If it doesn't prevent or detect a failure, you might reconsider, why have you been doing this for the last 5 years? This might be a good opportunity to stop doing unnecessary things in the lab that you're doing for QC. Again, IQCP gives you an opportunity to design your quality control in a much different way than you've been able to do in the past. I'm going to look at all these things: electronic procedural controls, equipment maintenance. Remember, it's not just liquid control, it's all these different processes for corrective action, your personnel training, your competencies, your equipment calibration. When you get a new assay in your laboratory, people are worried, okay, well, how do I do an IQCP if I haven't been running this test? Probably the biggest thing that's going to factor in your IQCP is that verification data. You're going to depend on that to help you make a decision on how you're going to write that IQCP. You're going to have to verify, CAP is really big, and that they're going to want you to verify those internal procedural electronic controls and make some sort of conclusion or decision, but it will be during that first time that you're setting up your verification data, and that's going to roll into your IQCP. Again, external controls. Again, you have to have your number, type, frequency, and acceptance criteria. Quality assessment. You guys are used to doing this. This is pretty routine for most labs. You have to monitor the 5 different components. You've really never said that before, but that's how it connects into your IQCP. You need to reevaluate your quality control when you've got a problem or failure in investigation. And it's to determine if quality activities are working according to your quality control plan. Again, the key word to keep all this straight, you're reviewing all these processes up on the board there. Again, you do this all the time, but again, you've got to link all this together. Again, I love this statement. Without quality assessment that came right out of that guide, it says you don't have a complete IQCP. So on the risk assessment, you say, has anything gone wrong? Quality control, how do I prevent or detect the failure? And ultimately, is this all working? And I'm going to stop at that point. Any questions on the basics? I think everybody's got the basics. I'm getting a lot of head nods. I guess that's positive communication this time after our last talk. Okay. I made a fictional test up from Acme Company's test instructions. And if Acme Company's test instruction package that says to run 2 levels of control each day, your decision obviously is not to do IQCP because you're fulfilling the requirement. So that knocks that one off the list. If it recommends QC frequency less than CLIA, which a lot do, you have to perform 2 levels of quality control because it's non-waived. Or you can do an IQCP. And then for Acme Company, if the QC protocols would be more costly than doing 2 controls daily, those are the first tests you should do in your laboratory for IQCP to save money. This is an example on these USB drives of what we provided to our customers. And first of all, we identify the failure, operator failure. Let's see if I don't know if this is the pointer or not. I'm scared to even use it, but no, it probably isn't. Operator failure, Not following manufacturer's instructions. Guess what? You teach that to everybody in medtech school. You need to read the instructions. Again, the category is a testing personnel. Potential effects of the failure. Every lab has to determine that themselves. We do not know the conditions in your laboratory, so that's part of the spreadsheet we have left blank for you guys. Our triage is really good in that we have a lot of mitigation features that are provided on the system, also in our labeling. Laboratory risk mitigation is what the lab can do to mitigate additional risk. And the severity and frequency has to be determined by the laboratory. Now, I know this question is going to come up, and I'm going to go ahead and address it in that CMS does not say specifically you have to look at severity or frequency. But I will caution you that my CLIA inspector, and they're going to vary from state to state, she made a comment that she really wants somebody to be looking at that as far as their evaluation. So that's the part that's subjective and gray that we're all going to find out about next year. And then laboratory documentation, that's your SOPs and policies and procedures for doing your documentation for your inspectors. I got this from Joint Commission presentation that I went to see at AACC, and I liked their format. You've got the 5 categories. You've got the phases of testing. So pre-analytic, analytic, go in that column. And I like this question. What are your possible sources of error? What can go wrong? That's your risk assessment. It says, can our identified sources of error be reduced? Yes or no? You want to say yes there and then provide your additional information there. It's not to say that you can do that for all things that go wrong in a laboratory. The answer can be no, but it's a little harder on those when you answer a no, because you're going to have to say, is the risk benefit worth a no to that answer? And the example, the one that's very straightforward to me, is emergency release blood. I think the hardest thing for getting ready on an IQCP is looking at all the things that could go wrong that really are not written out in the laboratory. There's a million pre-analytic things that can go wrong. So I like this example. They kind of put them and lump them all in a category by saying wrong sample type, incorrect anticoagulant, inadequate fill of tube, patient misidentification, labeling errors. So next column it says, can these be reduced? Yes. And then you put out to the side all the things that you do in your laboratory to prevent those things. Again, we've got it in the procedures, we've got it in the laboratory, but you're going to have to summarize it in a way that an inspector is going to feel that you actually looked at all these details. Again, bubbles in the air, or air in the sample, training competency, collection technique. Improper lancet capillary collection. You've gotten the wrong thing. It should have been lithium heparin. Got clots or inadequate mixing. Again, direct observation, policies and procedures. And I wanted to include about the step-by-step guide. Appendix D, I felt was really good because there's, for each category of the 5, great questions to remind you of all the things that can go wrong. So if you can't think of them all and you're not getting them cued by these software programs, if you're doing this on your own, you're going to have to think through and make sure you get them all. The environment, the temperature of the testing area, the humidity, again, monitoring all these things. You have procedures for that. You have those temperature charts, humidity charts. Testing area is like for a lateral flow, is not free of vibration. Again, appropriate test area. How about if you're a point of care coordinator and I'm sure you're all great point of care coordinators and you visit all your sites all the time, but maybe they moved it to a dirty closet on you and you didn't know about it. Make sure you're doing those audits and that people are doing their appropriate testing in the right place in the lab, in those point of care locations. Reagents. Again, reagent degradation, improper temperature upon receipt. Test device has a changed expiration date. For example, at triage, you educate people that if you want to change from holding the reagents at refrigerated temperature, that once you take it out, you label the date and time because it's only good for 14 days once you take it out to room temperature. Maybe they're not taking the device out immediately and using it and exposing it to long-term humidity. Again, all of this on the side, there are things in the lab that we've done all along, but you've got to do a summary in some way. And as you see, I've done the same spreadsheet again, but what I did was I took our manufacturer's spreadsheet and I started intermingling it through the Joint Commission examples. And so pick a template that you like, or you can design your own, but start somewhere. I'd say immediately pick, one that looks right, you're comfortable filling out, and then go forward. Again, the test system, ROM user ID, procedural controls, external controls. Do you have everything written out? What happens if they fail? Lockout is a great addition to your risk analysis. It becomes low risk if the system will lock out for you. Manual reporting. Do you have like a raw system for just, instead of manual entry for these results in the point of care setting, do you have a nice data management system that will make sure that the results are put to the chart? Testing personnel. You might have nurses, PRNs, that are not working very often. Again, you're going to have a different quality control plan for somebody that doesn't do the test very often. You might want to increase the number of controls that you're running on those in that testing area. They might be short-staffed. They might come on inspection and find they can't find their diplomas that they're required by CAP or their competencies in their trainings. Just make sure this is looping around in all the inspection process. Be careful, because it's almost like a tracer when they start going through your quality control plan. For a practice quality control plan, this one I got from the step-by-step guide. I thought it was a very nice summary. I made this big the first time, and I'll give you the big summary and what it would look like on a piece of paper. Again, procedural control. How often with each specimen? And then it says acceptance criteria must be documented as acceptable according to package insert on the quality control sheet prior to reporting results. Temperature checks, recording them. Again, you want to make sure that the ranges are specified in the things you do every day on your temperature on your refrigerators and your room temperatures. Verify specimen collection tubes. Again, pre-analytical. With each specimen, refer to specimen rejection logs, the things you've got that you have in place already. Improperly collected tubes. All this is included. Reagent device storage, which each device, document date and time on reagent device when removed from the refrigerator. Follow with package insert instructions for handling reagents. Training. With each new testing personnel and when indicated, successful demonstration of test performance. Document training activities. Last one, competency assessments. Non-wave, they're going to catch you on every 6 months. Remember, wave, they eliminated, you can do it once a year. Non-wave, you got to have that 6 months in there. The 6 components. Again, it's drilling it down, so they're going to be looking at this stuff when you present these plans. And I hope I got the overall. There's an overall summary that this was like a realization to me as working on this. There's my IQCP plan there, folks, right there. That's what that medical director, laboratory director is going to sign and say, this is what we're doing. And again, this is not all the possible QC procedures you can do for something, but basically it's going to be in a sheet summary like this, so that laboratory director knows exactly how everything's quality controlled. And this is about reviewing for quality assessment. Maybe when you reviewed your temperature logs, you found somebody didn't take a temperature on Friday. Again, what did you do? And you got to go back to remedial training of your personnel. You got to make sure they're doing everything correct. You got to look at, let's say there was a sample that was rejected. We discover it? Again, remedial training of processing personnel. Reassess processing procedures in your laboratory. Other ideas, review of your QC logs, your proficiency testing if you miss one. You guys are doing this anyhow. You've got to do these things, and they usually show up at quality assessment. Review training logs, FDA alerts, review personnel qualifications, and probably the hardest one is the keeping up with the competencies in the education. Again, SOP is not required, but good laboratory practice to consider. You're going to interlink these into your quality assessment and your quality control plan and your procedures. Our helpful hints. Don't do this alone. Get a group together. Don't cram your existing QC into your IQCP. This is your chance to make changes. They're going to remember your IQCP is going to be, your failures are going to be linked to your risk assessment, to your quality control procedures. If you're doing something that doesn't prevent a failure, you might be able to stop doing and save yourself some work. Multiple tests on a cartridge, devices in multiple locations, not one system IQCP. You're going to have to, either do an appendix, do a tab on your Excel spreadsheet, make sure you've identified differences. I think the CLIA inspectors, when the next step, if you have all the parts and everything looks wonderful, they're going to start looking at those things. Again, pick a spreadsheet. There's lots of them out there. And feel free to modify them to make them work for you. And do not, on our spreadsheet, we did not provide pre-analytical and post-analytical and analytic. We wanted you to determine those. We really focused on mostly analytic from being a manufacturer and helping with this process. Summarize your data for your inspectors. I think that will help you. I don't know if you, well, I know you've been involved in the inspection process, but I can tell you the more organized you are, and when an inspector comes in, most of the time, the easier the inspection because they know that you prepared for that moment when they're to walk in the door. Risk analysis doesn't have to be complicated. I like the risk analysis assessments that Joint Commission is saying to use. I think that's really cool. You can have those more complicated risk assessments like I showed you that we provide. That can just be the data. But if you want nice summaries and to make it easy to look at, I would consider using something more simple. Can't delegate at all. This is up to the laboratory director. I said it a million times because I don't want people to miss that. IQCP SOP can be incorporated into your existing quality control plan and quality assessment. Best guide out there is developing a step-by-step guide. Your biggest obstacle is just finding time. We all laughed when we said that. Delegate to your staff for looking up your data. If you need somebody to review all that quality control on those temperatures for the last 2 years, and you've got a tech sitting and working on an incubation in another lab, I would say, do you mind going through these and putting a tab on where we had corrective action? I would use people. Don't reinvent the wheel. Get an example template. You can get some things completed on your IQCP tomorrow if you've not started. Quit putting this off. Don't stress over doing this. It doesn't have to be a perfect IQCP. And keep it simple. So what are you guys going to be doing on New Year's? A lot of people like to sleep. A lot of people like to celebrate music. But please don't be that person that looks like me that I work every day from my home in my pajamas and bleary-eyed. Don't be that person. I hope you're not working on your IQCP. And with that, I'll take your questions. There's a hand if somebody will bring the mics.
Is frequency asking for how often this happens with your mitigations in place, or how often it happens before mitigation?
I think it includes mitigation because you're looking as the test exists today. That's my opinion.
Okay. Thank you.
You have to do the situation that you're in and then evaluate the frequency. So obviously, if you've got quality control in place and you've got procedural controls, a lot of those are going to be improbables if you have those features.
So what happened when we had dual employees that work in an organization that has several hospitals, but one does a wave and the other does a non-wave? Would that apply to the education part, or will that apply to other part of the IQCP? What would you do in that case? It will be educational, it will be...
Oh, for wave testing?
No, like, let's see the creatine and the iostat. Some places collect it in a syringe and some others in a green tube. So if you collect it in a green tube, it's wave. If you use it in a syringe, it's non-wave. But this employee travels back and forth. And what if that collected in the non-wave or the wave in the different hospital? So how would you address that situation?
We actually, I'll say on the speaker. I can do much better at like an example on a Lear test, but we sell a lot of tests that are dual waved and non-waved, and it will be by sample collection that makes the difference. So for us, serum HCG is non-waved, and so you would have to write an IQCP. So it would be the same case, I think, for an iStat. If it's waved, you don't have to do it. I assume you guys knew that, but non-waved, and for those exceptions, yes. And some comfort is that your risk is pretty low if you think about it for just a change in sample specimen, because it's already a wave test for, using it for urine. So you can very confidently, have probably low risk on most of that test just because it's a wave test to begin with. The only change is handling that blood sample, coming to the lab, spinning it down, and it becomes serum. Does that answer your question?
Yes.
Okay.
But also I was thinking that will the other hospital that does the wave be worried about it in case that the employee accidentally do the non-wave way, or they just make sure that they train and they know what they had to do in their respective hospital?
That will be part of your training. I honestly can say from listening to a lot of people, many labs are switching to as many wave tests as they can put their hands on, and they're just avoiding this like they don't want to do it. But yeah, again, it's going to be an education piece, especially for point of care, when you've got a mix of tests out there, waved and non-waved. You're going to have to be careful.
Any other questions? Can you guys share how you're doing with your IQCP?
Well, we started doing it alone, and I was wrong when we realized that we need help. So now we have a team of specialists working with us, have it here with us, and we found out that it's really helpful to have, different opinions, different point of view.
I encourage you you seem like a strong point of care group, that I don't know if you have email or you share, but in Tennessee, they've been actually, as people have completed their IQCPs, they have shared them by email by email to give people ideas on how to set them up. Also, if you are any Joint Commission inspected labs, I'm not talking Joint Commission hospitals, inspected by Joint Commission in here, you guys have a great resource. You can submit your IQCP to them in advance. They'll review it, and if they think it's good enough, they post it for your group to read. If you get it back and say, no, it's not quite good enough, you need to go home and work on it. But that's a really nice resource that Joint Commission is providing for their labs. There's a question, I think.
Thank you for your information. You addressed new instruments. Okay, we have ISTAT, we're starting ACTs, and our go-live date is December 15th. And so we're going to do our validation. But how long do you think I should be doing liquid quality control versus EQC before, so that I can validate that, oh, we can do it, whatever, once a month or twice a month or whatever, because we're not in the field, we're not active, you know?
Yeah.
So, and I know you can't have a definitive answer.
Actually, I
but-
can,
Okay,
because
good.
you're in a weird position. If I really don't think any inspector, CMS, Joint Commission, CAP, whoever inspects you, you're before the deadline, January 1st, and I truly would follow EQC for that short period and use that data and go forward. When you get to the January 1st, I don't think you need to do that, but I think like when I was inspected, I just really didn't want to have to argue with the inspector. I just wanted them to look at it and agree with me. I might not agree with what we were doing there exactly, but I knew what they were looking for, so I would prepare it that way. For you, I'm giving you an advice that I would do. Are you Joint Commission inspected? I would do an option 1 CLIA and sign off on it. Then use the data going forward to January 1st and say, we haven't had any quality control issues. It's working, and keep reviewing it and go forward. Now, this is going into theory instead of practical. EQC really was not a good way to do quality control, and this is why IQCP came to being. So just doing 10 days of quantitative values is not valid. Everybody knows that in the lab. I don't even know how that even got there, but it did. So I think going forward, you don't even have to do a mock EQC. I think there's other ways of looking at your internal electronic controls without doing any sort of study like that, that it's acceptable for an IQCP with a new test, because there really is no benchmark to follow. Just doing EQC is just doing the wrong QC, and that's, I think somebody might respect you more as an inspector going forward on January 1st if you'd started, that you designed your own study and decided, yes, you've got to check those internal controls, electronic controls, but you can do it in your own way, in a fashion that's useful. More questions?
What's the time to do it? Please ask.
So I'm sort of thinking of that. So I know you should be doing it per analyte. Should you be separating analyte on the different cartridges, or just per
Oh, yeah.
analyte?
You need to be careful. I mean, I'm not a point-of-care blood gas expert, but I kind of know certain things are more particular than others. So like a potassium, I know if it's hemolyzed, it's going to affect your patient results. You can't ignore certain analytes. There's a bunch, though, in my opinion, you can group in the same group. So it's those exceptions that you want to somehow, you know, it's the area of testing, if there's differences in personnel, and then also the analyte differences on a system. They will accept a system, you know, IQCP. Just don't forget the exceptions, because I think they will write a deficiency to folks if they haven't thought through that process. Yeah.
That was a good question. So let's see, the CG8 cartridge and the iStat has a blood panel and electrolytes. So let's see, the hemolysis only affect potassium. So can we just do and separate for potassium and the rest of the panel and then separate?
The only part is going to be noticing it on collection that you've got something in place for that, and also reporting because it affects the results. The analytics are the same. It'll be the same IQCP for the other parts. So just make sure you know, it's really
Included.
pre-analytical and post-analytics that you're going to have to worry about. I don't know that, I don't know iStats well enough to tell you if it would reject the sample. that would be cool. If we put it real low risk, it would, but I don't know how it works. More questions. This is your moment. Things you're worried about. It would give me time to talk about a couple things. First of all, I told you about the microbiology one. Are any of you guys partners with Cardinal Health in this area? This week, Dr. Koshi, who's my boss, did 2 webinars for Cardinal Health. It was the exact same slide set I just used, but he'll give you a different perspective than me. I'm a medical technologist, and I can give you my medical technologist viewpoint, and he'll give you more higher level PhD. I thought it was quite good. Just contact, if you didn't hear it, it's recorded, and you can rehear it. And it's the same slide deck, but you might want to listen to it. We also are going to be on White Hat October 22nd, 12 noon. This is Tennessee point of care. Same slide deck, but the person given it is not going to be me. I'm just going to be a panelist for questions, but her name is Edwina Zolag. She actually was a private consultant to laboratories in Florida, and Aaliyah persuaded her to quit her business and work for us. So she's going to be using the same slide deck, and again, she's going to give a very different viewpoint than me. So if you've got the time to, listen to it, and you need more information, you might want to.
Well, thank you very much, Jane.
And
it was
thank you.
very interesting to know your approach about IQCP. And we have an excellent idea of what to expect and what to do. Thank you very much for
Thank
being
you,
with us.
everyone. And use IQCP at Aaliyah.com. I'll be glad to answer your emails.